answer any questions. So investigator-initiated trials, cooperative groups, natural synergy. Great title that I gave someone, Linda or someone else, about a month ago. And it was a nice title, but I'm not sure what I was thinking at the time. So anyway, let me see. I've done this before. I've given a great title and then couldn't work out what I was thinking. All right. So I'm going to give some background about trials, which will really be just to say some very basic things. Talk a little bit about the Parkville Cancer Clinical Trials Unit so you understand how we do it and how we've integrated Parkville palliative care trials, and then talk about COGS and IIT and some novel trial strategies. I noticed on the agenda that Peter Gibbs is talking about registry trials, so I've taken out a whole lot of slides with respect to registry, although I will cover it very briefly just to explain what it is and give you a taste. So my background, as Brian has alluded to, medical oncologist, mainly doing brain, director of the clinical trials unit here. I'm old enough to have practiced palliative care as part of my medical oncology training and early medical oncology days. I've been an investigator on lots of commercial trials, cooperative group trials, a handful of investigator-initiated trials. I was, Brian was my registrar way back then, as he said. And I was the inaugural chair of Cogno, and I have made every mistake there is to make in the world of clinical trials. So if you want an expert in what not to do, I am that person. So I have an aphorism, and I get that this is the palliative care trials cooperative group. So I'm not really telling you anything you don't know, but clinical trial medicine is good medicine. Care is better. There's attention to detail. It's protocol driven, lots of TLC, and it's not the Mark Rosenthal near enough is good enough approach to clinical trials. Outcomes are better, probably. It provides options and opportunity, and clinical trials provides early access to new efficacious drugs in many instances. And importantly, and it goes for patients with curable disease, incurable disease, and in palliative care, it provides hope, optimism, and I think also a sense of altruism. For medical science, of course, it demonstrates what works, what doesn't work, what might work, and how to move it forward. We all understand that global winners are infrequent, whether that's a new drug, a new technology, a new device, a new approach to quality of life, whatever it might be. And it costs a lot of money to take something from a laboratory observation to registration. For investigators, it's a core professional component for many of us. It's hard work, there's no doubting that. And I won't go into it, but we know that the clinical trial portfolios that we run have got more and more complicated, not just the phase 1 studies, but right through to phase 3 and phase 4, whether it's whichever craft group it might be. There's an enormous amount of academic satisfaction, and it's important for some CVs and careers. What are we trying to achieve? Well, clinical benefit, of course, access and participation. So they're two different things. And access in particular, as well as participation, is complicated in Australia because of the geographical distances. But participation also means equity. We want equity in gender, race, language and culture, AYA, adolescent, young adult, and financial equity. What have I learned about palliative care trials in particular? Well, there are clearly lots of questions to ask in the palliative care setting. Of course, there are lots of patients. There's an increasing trial portfolio, increasing expertise and experience, both with investigators and trial research staff, increasing collaborations and networks. Patients and families are very willing participants, even in the last month of life. So, you know, as I'll go into, we brought palliative care and Brian's trial program into the trial unit at Royal Melbourne, I'm guessing 15 years ago, or close to, maybe just over 10 years ago. We saw it as an important part of cancer medicine and cancer clinical trials. And from a small handful of trials and a really small group of palliative care clinicians working in the clinical trial portfolio space, I've seen it increase. I think the VCCC, when it commenced, whatever that was, 5 or 6 years ago, we focused deliberately on palliative care trials. And I pushed very hard for palliative care to receive funding and resourcing and support from the VCCC, the Victorian Comprehensive Cancer Centre, because I think it's a great strength, palliative care in Australia, and it should be undertaking clinical trials. The Parkville Cancer Clinical Trials Unit was really a merge between the Royal Melbourne Cancer Trials Unit, the Peter Mac Cancer Trials Unit, and the Women's Cancer Trials Unit in 2016. So we're about 7 years old now. We're a combined unit of a number of craft groups: haematology, medical oncology, palliative care, nuclear medicine, and surgical oncology. And I suspect there aren't too many clinical trial units in Australia that are medical oncology and haematology combined. That's a little unusual. And Brian, you can probably tell me, but I doubt that there are too many centres with haematology, medical oncology, and palliative care as part of a group. We have very strong links to basic and translational research across some research centres. And it's really a medium-sized business, 120 staff, 29 million in revenue. It's a not-for-profit, but it's also not for loss. We have over 200 open and accruing trials, maybe 60 or 70 investigators. We have about 80 new trials a year, almost half are first time in human or phase 1. So we are hardcore early phase drug development type trials. And yet we still have palliative care as part of our portfolio. And we accrue over 500 to 600 patients a year. So palliative care and the PCCTU itself, as I said, it's been a long-standing craft group within at least the Royal Melbourne component of the PCCTU, and now PCCTU proper. It has the status of any other craft group within the PCCTU, whether it's medical oncology, haematology, nuclear medicine, surgical oncology. What do we offer here? Well, we offer expertise, experience, and the operational model to conduct cancer clinical trials. We use Cancer Trials Australia, which you may or may not be familiar with. That's the site management, not the trial conduct. So site management through CTA allows us to really hand over budgets, contracts, finance, HREC submissions and amendments, all the things that the research staff should not be doing and wasting their time doing, and all the things that investigators like myself are not very good at. We hand that over to Cancer Trials Australia, who recently celebrated its 30th year. And Cancer Trials Australia now has something like 37 sites around Australia. It does all of that work and frees up the time and resources for a clinical trial unit like ours. We're a very big unit, but even small units, it can free up time. The PCCTU also provides a feasibility program, the research staff, the education, the training and development. There are economies of scale, and the sum is greater than its parts. So the benefit for all of the craft groups, including palliative care, is it's not a small operation run by individuals with a small number of staff. It's a huge organisation that lends itself to provide all of these elements. There are, in particular, the sort of model of operations is really important. What we do is we have a single cost centre, and all trial revenues come to that cost centre. What we don't have is stream or craft group sub-accounts. So if I make a lot of money in the brain craft group, our team, I don't know really how much each trial is making or losing. And the same goes for palliative care. So in fact, what happens in the PCCTU is that studies that lose money, particularly the IIT and the cooperative group trials, are subsidised by studies that make money. And in fact, we make a lot of money because of the early phase focus. Early phase trials make a lot of money. And we have registered surpluses in 5 out of our 6 years of work. That means that the palliative care trials and the brain cancer trials and the breast cancer trials that don't earn money, IIT and cooperative group trials, are subsidised and have a significant place within the PCCTU. Surpluses are reinvested. So whilst Brian gives up the money that he might earn from a trial, that goes back into the PCCTU. It gets reinvested into education programs. It gets reinvested into increasing the staff. It gets reinvested in all sorts of ways that, broadly speaking, assist the clinical trial programs of palliative care or the brain group or the breast team or whoever it might be. One important factor, even though it's my way or the highway, as director, it's my way or the highway. Brian, you have to do it this way or you can get out. But actually Brian has, and all of the craft groups have the ability to decide what trials they want to do. So the trial leads, like Brian for palliative care, they have autonomy in their decision-making. I don't try and tell the breast cancer doctors which breast cancer trials they do. They've got to do it our way, but they can do what they like. So in terms of the trial mix for the trials unit of the PCCT, overall we've got just over 200 trials open and accruing. As you can see, the majority, over almost 2/3, are sponsored, commercially sponsored studies, and about 1/3 are cooperative group studies, and about 10% would be investigator-initiated trials. What that means is essentially that the cooperative group trials and the IIT studies can be subsidised by the sponsored studies. And in palliative care, I think we've got 5 open trials at the moment, 3 of which are cooperative group and 2 are IIT. So, you know, there's not much money coming in from the palliative care trials opened at the moment. And often, I think, you know, broadly speaking, palliative care in itself probably doesn't attract that much sponsored. It doesn't have attraction for sponsors as in terms of new drugs and fully sponsored trials. So, you know, being part of the PCCTU is to the advantage of palliative care because we can subsidise studies. Okay, so getting sort of to the topic at hand, investigator-initiated trials and cooperative group trials. You know, what's the synergy? How do they work? So, you know, if we look at investigator-initiated and cooperative group, if I just run through things, you know, where are they done? Well, generally speaking, the investigator-initiated trials are local, whereas cooperative group trials are national. The number of sites usually pretty limited for investigator-initiated, multi-site for cooperative groups. The design, hopefully, both are pretty simple. The question that's being asked, I think of investigator-initiated trials as asking, are really about being feasibility trials or patterns of care studies or some scientific question that is very specific. But fundamentally, I think particularly for palliative care and clinical oncology, it should be about feasibility, whereas the cooperative group trials are really asking a very specific clinical question to change clinical care. In terms of accrual, investigator-initiated would be modest. Cooperative group trials are often large, randomised phase 2 or randomised phase 3 studies. Both are based around standards of care, so the way to avoid expensive investigator-initiated trials or cooperative group trials is to base them around standard of care so that we're not spending a lot of money on MRIs that wouldn't normally be done, for example. And I think the key here, and perhaps the point that I really want to make in this presentation, is that they have quite different purposes. To me, the cooperative group trials have to be focused on practice changing, whereas, and I'm happy to take commentary back regarding this, whereas the purpose of an investigator-initiated trial, I think, is more about leading to a more expansive trial. It's the basis of working towards a cooperative group study. The cost of an IIT is generally modest. The cost of a cooperative group trial is almost always significant. Funding is difficult to obtain for both. And the speed to open, it's always slow with an investigator-initiated trial. I reckon it's really slow with a cooperative group trial. You guys might do it really quickly, but I can tell you Cogno was, you know, slow and slow and slow. And who's in charge? I think this is important too. I think, you know, an IIT is the investigator. He decides the question. They ask the question. They are the ones responsible for the idea. Whereas cooperative group trials inevitably are designed by committee, which sometimes can blur the lines of what's important and what's not. Okay, so here's my starting point. What's the synergy? It was actually interesting to think about this because I hadn't really thought about it until I wrote this. An investigator-initiated trial, I think, should inform the next cooperative group trial. Investigator-initiated trials, for the reasons that I've just alluded to, they're small, local, asking a feasibility question almost invariably, whereas the cooperative group trials are quite a different beast. Well, how does an IIT inform the cooperative group? I think you've got to ask a worthwhile question that pricks the interest of a cooperative group. You need to demonstrate feasibility. I always talk about it, even in our phase 1 studies. Can you take the drug from the factory and put it in a human and not kill them? That's not a bad feasibility study. So, in palliative care, can you do the intervention that you say you're going to do? And can you get data from that intervention? Feasibility can be very simple. But if it asks a worthwhile question and you can demonstrate feasibility, then perhaps you might create some broad interest across the cooperative group matrix. You've got some data that you can examine, and it might form the basis of a funding application. And as I said, that might engage the craft community, the palliative care community. So doing an IIT has the ability to inform a potential cooperative group study, and you've got to do it once and you've got to do it well. Ask a good question that resonates with people. Demonstrate that it's feasible to do a 10 or 15 or 20 patient clinical trial that demonstrates feasibility. Create the interest, provide the data, get some, it can assist in a funding application. Do it once and do it well. Okay, I'm just going to take a few quick minutes to discuss, really raise 2 novel approaches to palliative care trials. So, we've got the IIT, we've got the cooperative group trials, but can we do palliative care trials in a different way? I'm going to talk about two elements, teletrials and randomized registry trials. Why teletrials? Well, it's obvious. 1/3 of our population are regional, rural or remote, and that's increasing. And they've got small trial units. I think actually the access to cancer services in regional cities is very good. They get very good care. I don't know about palliative care, I can't speak to that, but certainly medical oncology and radiation oncology, it's very good. But they have modest trial units. And for regional patients, and in fact metro patients on trials at metro centres, travel time can be burdensome, care may be compromised. So if you come from out of Melbourne, on a Wednesday morning at 9 o'clock, you're in traffic that takes you an hour and a half to get to Peter Mac and home. Your daughter has to find someone to look after the kids. It's very time consuming and burdensome, and care might be compromised. Well, look, I don't know about you guys, but telehealth and telemedicine has been absolutely transformational. So teletrials can work in different ways. You have the metro centre, let's say Peter MacCallum, where I am, that is the primary site and does everything. But you might have regional sites that are satellite sites that do some of the work, whether it's give treatment, do some of the tests, even just do a simple blood test to save the patient coming all the way in. And I think we need to go metro to metro. So from out of Melbourne to Peter Mac, there must be a way of doing some teletrials to try and save the effort required from a patient. Lots of benefits, increased equity of access, opportunities for recruitment, collaboration and networking, and developing capability in workforce. Does it work, you might ask? Well, we've got 3 trials open at the moment. This was a very successful trial, a thromboprophylaxis study, randomized phase 3, enoxaparin based on a predictive model. That's not a bad accrual graph. You don't see that very often. The median distance for patients from the primary site, that was Peter Mac, was over 200 Ks. This was a study that was done in Ballarat, Bendigo and Albury, and 52K from satellite sites. The recruitment was really quick, 10 patients per month. It's a pretty simple study. Nearly half were from the regional sites. Now, if you're an investigator, that makes really good sense to invoke a teletrials strategy. We actually have done a teletrial in an AYA group where Peter Mac is the satellite site for the Children's Hospital. It's only, it's half a kilometre down the road, but it made sense to do that. So teletrials are actually pretty challenging, but it does increase equity and participation, reduces the logistical burden for patients and families, increases accrual, and there have been no issues in conduct or quality. Now, I think it's the way of the future. Cogno hasn't really embraced teletrials. I wish it did. I'm not involved directly anymore, but I think if there's something that you can get from this talk, embracing a teletrial strategy would make a huge difference to the clinical trial landscape for patients and their families and for investigators in palliative care. I'm just going to very briefly touch on randomised trials because I see that Peter Gibbs is going to talk at your next meeting, and he's a great advocate and really the champion of this. Why randomised registry trials? More generous inclusion criteria, real world population, quick and inexpensive and simple. Does it work? Well, yes, it works. This is back from 2013. Angioplasty versus angioplasty and thrombus aspiration. So thrombus aspiration became the sort of technique de rigueur at the time. Did it change mortality? The answer is no, it didn't. They put 7,000 patients in less than 3 years at $50 a patient. So this is a randomized registry trial. We did it in brain cancer, extended temozolomide, it's a brain cancer drug. Some patients were getting more than 6 months, which is the routine, and it was glioblastoma post-temozolomide, which they get 6 months of, consent, randomisation, no more chemo versus continuing. Overall survival was the endpoint, and that's been a very successful trial. Here's the CRF, 1 page. Got all the information, 1 page. And I won't go into any more detail except to say, again, I think this is something that should become a routine component of our trial portfolios. And cooperative groups in particular are well placed to adopt this particular design. So a conclusion slide. IITs and cooperative groups. First of all, I think palliative care is a fertile ground for clinical research, clinical trials in particular. There is increasing interest, experience and expertise. I think, as I've said, there's benefit in leveraging large trial units. Brian can comment when I finished about how he perceives working within the PCCTU structure. I think investigator-initiated trials are a key to inform cooperative group trials. Funding remains an issue, of course, that's difficult. And novel strategies should be embraced. So registry trials, teletrials, these sorts of strategies, particularly for palliative care trials, I think would be really worthwhile. So I'm going to finish there. Let me just stop, if I can stop sharing. Brian, I'm sort of interested to hear what you think about being part of the PCCTU, but then happy to answer any other questions.
Well, firstly, thanks, Mark. That was a brilliant talk. I think there's lots of different aspects to think about. The presenter doesn't usually start with a question, but it certainly had, it would be certainly difficult to envisage being where we are without being part of the larger clinical trials group at our centre. I think we do have a sponsored study at the moment, which is hopefully contributing to the kitty, but it has been useful to not have to worry so much about the break-even point and sustainability of our trials and being able to support investigator-initiated studies. But beyond that, it's been good to be part of the team, really, and just hearing the issues that other people are going through, which are largely the same as the issues that we're going through: recruitment, budgets, ethics, and yeah, so it's been fantastic from that perspective. Mark, thanks so much for your time this afternoon. I think we've kept you longer than originally planned, so
my pleasure.
You know, it's been terrific to Actually, I'm wondering whether you actually did cover the title of your talk as planned, but
Oh, come on.
you did and more, of course.
Yeah, all right, good, thanks. Okay,
All
thanks
right.
everyone.
Thanks very much, Mark.